Good evening, everyone. So let's get a little bit of 3D imaging by the end of the day. This is basically a workshop. It's not a hands-on workshop, but I'll let you go through a lot of how to do 3D imaging, how to take views, starting from the intubation of the 3D probe, uh, even from the anesthesia of the patient, and different views, and how to assess specifically the mitral valve. We'll go through a lot of spectrum of the mitral valve disease, including prolapse, flail valves, cleft valves, dehiscent valves, even paravalvular leaks, real images. Most of the images basically, I'm not going to talk a lot. There is not a lot of like phrases, paragraphs. It's going to be everything like demonstrative. So this is just the beginning. You can see from the clip over there that this is basically, it stopped working, sorry. This is basically the emphasis of the or the surgical view or the atrial view of the mitral valve in a short axis, 3D TE. You can see that there is here a chordal tendon rupture and a prolapse of the A2 or the middle scalp of the anterior mitral leaflet. And this is the same surgical view live for the same patient. So let's go through the slides and see through the time machine of the echo, where Professor Idler in 1952, who is regarded as the father of echo, he invented first of all the M mode. So you can see that starting from 1952, there was only M mode. And then after more than 10 years, they started to have a 2D after the technology evolved. And then first human 3D TE was reported in 1992. So that was still a long time back, not the 3D, the 2D TE. And then after 10 years more, we got to find something called photorealistic view of the mitral valve, which is basically a trans-illumination of the echo probe where you can reflect lights on the mitral valve while you're intubating the patient with the probe, and you can see everything in details, specifically just like the surgeon view. So in order to know how to do proper 3D TE, we have to get to know the complex anatomy of the mitral valve. It's not a normal valve like the other valves. It's very complex. There's a lot of structures inside the mitral valve. You have to know the parameters. You have to know that all the structures in the mitral valve are basically 3D and it's not 2D. So let's start, for example, with the annulus. You can see the annulus, and then you can go with the leaflets, the anterior and the posterior leaflet. And then the commissures on both sides, anterolateral commission, posteromedial commission. Subvalvular apparatus, you can never see the subvalvular apparatus in the surgical view. You have to go to the LV view to see the subvalvular apparatus. Subvalvular apparatus basically is the chordae tendineae and the papillary muscles, which is the suspension system of the mitral valve. And very importantly is mitral aortic curtain. And this is what separates the mitral annulus from the aortic annulus. We'll see in details. Next slides. Yeah, again, the mitral valve complex, you can see that it's really complex. It's not just a valve. So here, this is anterior mitral leaflet, and this is a posterior mitral leaflet. There is many types of chordae, as you can see here. It's not one type of chordae. There is secondary and primary chordae, and these ones are responsible for the chordal rupture when the patient had flail valve with severe mitral regurg. So this is a chordae tendineae, and this is a papillary muscles. Papillary muscles are responsible for the contraction. Chordae are responsible for the elasticity. They are two different structures. And this is a curtain that I told you about. This is basically a membranous part that separates the annulus of the mitral valve from the aortic valve. So this is an MRI image for the anterior mitral leaflet and the hinge point, as you can see here, so we can depict the annulus specifically. Look at the annulus here. It's not a 2D structure. It's basically a 3D saddle-shaped configuration with two lowest trigons, as you can see here. So it is basically the junction between the atrium and the valvular tissue. So the annulus, it has to be measured by the echocardiographer, both in the 2D and the 3D measures, especially if you have, for example, severe valvular lesions like severe tricuspid regurg. Before the surgery, you have really to measure the annulus to see the cutoff. Is it really increased or not? So next is the anterior leaflet. You can see that it constitutes only 1/3 of the whole annular parameter. And the posterior leaflet, with its scallops, it constitutes the 2/3 of the annulus. So there are 3 scallops of the anterior leaflet, A1, A2, A3, and 3 for the posterior leaflets, A1, P2, P3. And there's two attachments for the anterior mitral leaflet. One attachment is a smooth zone, and the other is a rough zone because of the chorditendiny, as you can see. This is, they call it the coaptation zone to the chorditendiny. This is a posterior leaflet. It's completely different in the anatomy from the anterior leaflet. You can see that there is indentations here, two indentations that split the scallops of the posterior leaflets into 3 scallops, P1, P2, and P3. And then the commissures. I'm sure you're all including your commissural views and the assessment of the commissures in patients who have rheumatic mitral stenosis in the echo. Whenever you send the patient for either percutaneous mitral valvoplasty or surgery, you have to make sure that these commissures are fused or not, or are calcified or not. This adds to your score, the echo score. So it's very nice. You can see the 3D here shows a very detailed view of the commissures. This is an anterolateral commissure. This is a posterior medial commissure. And then comes the mitral aortic curtain. The mitral aortic curtain basically is the membrane or the connective tissue band that separates between the mitral annulus and the aortic annulus. This is the place of the curtain over here in this asterisk. So you can see this is a continuation from the aorta to the anterior mitral leaflet. I'm sure you're all aware of this complication here. This is basically the very famous wind socket deformity of the ruptured sinus of Valsalva. And it occurred at the same place here, which is the mitral aortic curtain. And then comes a very complex structure, which is the subvalvular apparatus. See, the subvalvular apparatus is not easy to comprehend, because you can see it's pretty complex. There are papillary muscles, and there's a lot of huge number of chorditendinae attached to the papillary muscles. Just imagine the suspension system of a car. This is exactly the suspension system of the mitral valve. So if you have a ruptured papillary muscle or a chorditendinae, your suspension system is already a crap, so it doesn't work anymore. So you end up with severe regurg. Either it was acute or a chronic one. So how do you take the views of the mitral valve? Through the 2D TE. We'll start with the 2D first. So this is a surgeon view, or like we say, the atrial view, which is opposite of the left ventricular view, or the MFAS view. You can see here that whenever you just move with the probe, you will get different anatomy of the valve. So this is a 5-chamber view. You can see here that you can see the A1 and P1 scallops of the anterior and mitral, anterior posterior mitral leaflet. So if you go further, like 45 degrees with the probe, you'll go with the 4-chamber. In this case, you will end up seeing the A2 and P2. This is very important in the pathology. When you have a pathological abnormality in the valve, you can determine from the 2D echo, especially the 3D, where is the pathology exactly, and which scallop, because it's important for the surgeon to know that before going through the surgery. If you move further with the angle 90 degrees, 60 degrees to 90 degrees, you will get something called commissural view. So the commissural view, you can see the left atrial appendage and P1, A2, and P3. So if you have a problem with the valve, like let's say a flail posterior mitral leaflet, you can see from here, from these views, which scallop is affected and cause this severe regurg. If you go further, 120 degrees, then you go with the 2-chamber views. You will find that here you can see the P3 and A2. And go further, 120 degrees, 140 degrees, then you go with the 3-chamber view. So there is the aorta. That's why it's called 3-chamber view. Basically, you have the atria, the ventricle, and P2 and A2 scallops of both the anterior and posterior mitral leaflet, and the whole aorta with a big part of the ascending aorta you can show. So this is the base of the heart. It's a bit complex also to determine how can you really imagine or demonstrate the base of the heart. So just imagine that the base of the heart is your fist, okay? So the left atrial appendage will just be medial to your fist up there, and then the posterior anterior leaflet will be right there over here, and the anterior leaflet will be opposing to the aorta. So the aorta is more anterior, and we will see from the next views this configuration, because if you're acquiring the picture in the 3D echo and you don't have this anatomy, that means it's a wrong picture. You have to rotate the image in order to get this view exactly. So let's start with the TE mid-esophageal view. You're still at 0 degrees. You just intubated the patient. You're still at 0 degrees. And you can see here that if you cut with your probe at 0 angle, you will go through these scallops over here, A2 and P2. You can see it from here in the anatomy. So you cut through A2 and P2. If you have a pathology like a prolapse or flail or cleft valve, you will see it here in this view. So what if you go up a little bit with the probe, just withdraw the probe a little bit up, like 2 centimeters only, then you will have a different view, a different cut through this scallops, which is basically A1 and A2 over here. And then you will pass by the aorta itself, which is over here. So this is very important for the pathology. Still, you are at 0 degrees, mid-esophageal view. This is basically the most common view we use when we scan the patient, especially the mitral valve, the mid-esophageal view. So right here, if you advance further inside the patient or retroflex a little bit, then you will be able to see a posterior medial commissure. So in this point, you will cut through completely different part or anatomy, which is A3 and P3. Again, the pathology here determines what exactly are you seeing. Then we change degrees of the probe, turns it to 60 degrees. Instead of 0 degrees, you just go with 60 degrees. This is basically the commissure view. So you will cut through the commissures. And you can see here that there's a left atrial appendage over there. You can see it clearly. You can assess if there is any clots, thrombus, even the pectinate muscle. Sometimes it's confused with clots. You can even measure the pulsed wave velocity across the LAA. If you're considering that this patient had AF and you need to cardiovert, you have to make sure the velocity is above 45 meters per second. So here you can see 3 scallops, P3, A2, and P1. And lastly, this is a mid-esophageal view, which is basically the long axis view because you added the aorta in addition to the 2 chamber. So now you can see the mitral aortic curtain in case you have any ruptured sinus of Valsalva. You will be able to see it here. This is the right coronary cusp, non-coronary cusp, and left coronary cusp. It's a very nice view. And again, you're cutting through a different orthogonal angle. Then you can see here only P2 and A2. So if there's a prolapse in either one, you will see it over here as well. This is all about the TD. So you have to be a game changer in order to be a really professional imager, to do a proper 3D. Because you have to give a lot of information to the surgeon before the patient goes to surgery. And you have to decide whether the patient has to go through a structural intervention procedure or open heart surgery. So this is basically the great revolution of the 3D echo. I'm sure Dr. Walid can relate to this picture. You can see it on a weekly basis, live. We're not seeing this live. So we just see this view over here, which we call it the atrial view or the in-face view. Surgeon view as well of the patient. And you can see that this is the same perspective from the echo. Look at here, you can see exactly everything in the valve as in here. So you can determine if there is any prolapse, any flail valve, any cleft, any pathology. And still you can do even 3D color, where you can determine everything in details. The vena contracta, the hemodynamics as well. You can measure everything. By the way, this slide is not mine. It's basically a courtesy of my dear colleague, Corrado Fiore. He's working in Città del Lecce Hospital. He's a very good expert in TE. So thank him for the slides. So this is a 3D TUN surgeon's view, like we just talked about it. So this is the orientation you have to make sure while you're doing the 3D that you have the aortic valve at 12 o'clock position, which is anterior. And then you have the interatrial septum at the medial part and the LA appendage on the lateral part. So what do you see here? We just talked about that this is the anterior leaflet and this is the posterior leaflet. This is scallops. So this is basically the posterior scallops. So that would be P1, P2, and P3. So we cut through here, and this is a mitral annulus. There is some pathology here. By the way, you can stop me anytime. It's supposed to be an interactive workshop. So I don't think it's a good idea to wait till the end and then we go back through the videos once again. So if you have any comment, if you'd like to comment on the pathology here, you can go ahead. If you want to guess also, it's okay. Yes, Dr. Walid?
It looks like a P2 prolapse with ruptured chordae in the P2.
Wonderful. It's basically put P2P3. That's right. That's right. And you can see here the chordae tendineae, this small structure, it's completely ruptured. That's why the scallop is prolapsed and completely flailed. So flailed, that means there is no any attachment anymore with the annulus or the leaflet of the valve. And that can cause, for example, a severe eccentric mitral regurg. And that's what needs repair for sure. So that's a very good guess. So 3D anatomy of the mitral valve. First, rule in the anatomy and orientation. Like we said, we have to have a proper orientation. 3 landmarks, like I said. Aortic valve, anterior. Interatrial septum, medial, and left atrial appendage, lateral. You have to get this view. Otherwise, you will not have a proper orientation. Okay, so this is the orientation of the valve. Again, medial is the interatrial septum. Anterior is the aorta, 12 o'clock, and left atrial appendage is lateral. What do you see here? The same that we've seen in the other one, but this is a base of like a photorealistic photo of the 3D image. It's more advanced. You can see clearly the prolapsed valve and the flail, and either the chordae tendineae rupture as well. Okay, so I'm sure you have heard about the Carpentier's classification. This is very important, and I'm sure each echocardiographer has to put in his echo report the mechanism of mitral regurg. Is it a Carpentier type 1 or type 2, type 3A or B? So what's actually the types? You can see here that type 1 is basically the leaflet is completely normal. The motion is normal, but there's something wrong with the leaflet. So it's either annular dilatation or a cleft valve, but the motion is completely fine. However, in type 2, there is increased leaflet motion with the opposite of type 1. And this is basically what we're talking about in the previous ones, prolapse or flail, because prolapse or flail is not a normal motion of the valve. Type 3A and type 3B is basically restricted leaflet motions, but the difference is type 3A has restricted motion in both systole and diastole, like for example, rheumatic mitral stenosis. You have restriction in both leaflets and during systole and diastole. However, type 3B, you will have only restricted motion during systole, which is like ischemic or dilated cardiomyopathy, due to as well annual dilatation. Let's see examples over here. Type 1, you can see here that this is basically normal motion of the leaflet, but there is a bit of like cleft leaflet. Over here, you can see the cleft over there. So the motion is normal, but there's a cleft leaflet. Here, the motion is not normal at all, because you can see over here that this is a prolapsed valve with a chordae tendineae rupture. This is a posterior mitral leaflet. Anterior mitral leaflet is fine, but the posterior mitral leaflet is prolapsed and flail as well. So you have an abnormal motion of the valve. Next one, like we said, a patient who has rheumatic mitral disease. Rheumatic mitral stenosis is a typical hockey stick appearance and the calcification of the tips of the leaflets of the mitral valve, limited mobility of the posterior mitral leaflet, and restricted mobility as well as calcification of the anterior mitral leaflet. And last is the type 3B, which we spoke about it, that you have restriction of the leaflet only in systole. So if it's only in systole, that means it's not traumatic. It's basically another mechanism, which can be ischemic or dilated cardiomyopathy, as in here. So here you will have tethering of the valve. Okay, so let's go one by one. I'll just go very fast and then we'll go through some cases. So you can see in type 1, we said it's normal leaflet motion. You have annular dilatation, leaflet perforation, or cleft. So this is the 3 mechanisms that are responsible to have a mitral regurg, and we call it here type 1 normal leaflet motion. Either a perf, a cleft, which is a congenital one, and annular dilatation. As in here. Look exactly what's going on here. This is basically a dilated cardiomyopathy patient, and you can see there is a malcoaptation of the mitral valve and annular dilatation. The valve looks completely fine. There is no prolapse, there is no flail, there is no cleft valve, and there is central significant mitral regurg due to the annular dilatation. Again, this is a leaflet perforation, which is also type 1. It's a normal motion of the valve. You can see that the valve is moving completely normal. But the problem that there is a cleft. Can you see here, this is a gap here, then echo free space. This is a cleft. And look at the color. There's a severe mitral regurg from this cleft part of the valve. Okay, so this is basically a congenital anomaly and it needs repair for sure. Again, this is a cleft. Look at this. This is a posterior mitral commissure, anterior lateral commissure, and this is a cleft. You cannot see the cleft in systole very well. We have to wait for diastole to see the cleft properly. Type 2 degenerative mitral disease like bellowing, fibromuscular dysplasia, flail valve, prolapsed valve. There's a lot of differences between them, by the way, but many of them is fibrodegenerative disease. So this is type 2. We spoke about that. This is not a normal leaflet motion. There is an increased leaflet motion. We'll see some examples here. This is fibroelastic deficiency patients, because this is basically the mechanism of prolapse. And this is an increased intensity of the fibroelastic deficiency. So you can see here that this segment over there is prolapsed. And this is basically from the P1. And here again, the fibroelastic deficiency is more extensive. And this is a more extensive form, which is the Barlow's disease. I'm sure you heard about the Barlow's disease. You have to have bilateral leaflet degenerative disease in order to have Barlow disease, not only one leaflet. It has to be both leaflets. This is type 3A, where you have restricted leaflet motion in both systole and diastole. That means rheumatic heart disease. Just imagine it. So you'll see that every single thing which we know about the rheumatic heart disease, the hockey stick appearance, and of the anterior mitral leaflet over here, dooming, and there's also a lot of calcification, the mitral leaflets, limited mobility of the posterior mitral leaflet. And this is the main features of the rheumatic mitral stenosis, as you can see here. Again, this is very nice and obvious clearly here. The hockey stick or the dooming of the anterior mitral leaflet, limited mobility of the posterior mitral leaflet, calcification, significant calcification, in fact, of both leaflets, anterior and posterior. And moreover, the commissure fusion. It's a very nice 3D image where you can see the commission here. You don't see really the commission quite obvious in the 2D echo, especially if the patient doesn't have quite a nice view. So look at the commissions here. They are fused. There is no space in both anterolateral and posteromedial commissure. So both of them are fused. And this is a free edges calcification like we spoke about. Okay, so this is the last thing, the subvalvular apparatus calcification. It's one of the scores. If you have severe calcification of the subvalvular apparatus, you don't have to take the patient actually to percutaneous valvoplasty. So you can see here a lot of calcification in the subvalvular apparatus and papillary muscles. And here there's a commissural fusion. This is a left atrial perspective or the surgeon view. This is the LV view. And this is the commissures on both sides. Type 3B, this is the last one, which is ischemic and dilated cardiomyopathy, where you have tethering of the valve because of the restricted leaflet motion in only systole. So tethering causes regurg. It depends about the type of tethering and in which leaflet. You will have a central or eccentric regurg. Exactly as in here. This is asymmetric tethering due to ischemic cardiomyopathy. So you can see that the regurg is completely eccentric with a Quanda effect. And it's shown here very nice in the 3D. There's a coaptation gap, as you can see here. And this is the opposite. This is a patient with dilated cardiomyopathy. So you will have a central tethering of the valve. So that means the regurg will be central. It will not be eccentric. And again, there is a huge coaptation gap. Okay, so this is another examples. You have usually to measure the annulus in this commissure view. This is the best view to measure the annulus of the patient. Here, sure, there is an annular dilatation. And in this patient, there is chordal rupture. You can see from the 3D echo, TE, that this is a prolapse of the P2 with a flail valve and a chordal rupture. You can see it very clearly. And this patient for sure will have severe mitral regurg. However, this is a patient who has dilated or ischemic cardiomyopathy, and usually they will have tethering. And specifically, this patient have DCM. That's why the regurg is central, and it's not eccentric as will be the regurg when the patient has flail or prolapse. This is like a fire shot of some slides. We'll just go through it very fast. You can see this is a mitral tissue dehiscence of a mitral valve. See this gap? This is usually what causes a paravalvular leak of the patient. And this is another patient where you have here a paravalvular leak in the 2D. See, there is no valvular leak at all. The whole valve is intact. However, there is a dehiscence of the valve. That's why the leak is paravalvular, outside the rim of the valve. And you can see here the catheter and the occluder device after fixation of the valve. Again, this is a very nice example of a dehisced segment of an annuloplasty ring which was implanted to the patient. You can see here that there is a gap. It's like a displacement or dislocation from the whole valve. So this gap will cause for sure severe paravalvular leak, as you can see here. This is a very nice example as well for the dehisced segment. This is a biprosthetic valve. It's not a mechanical valve. So again, this is a dehisced segment that will cause a paravalvular leak. Usually, if you have a one gap or one paravalvular leak, you can, in a high-risk patients or even in moderate-risk patients, you don't have to take the patient to surgery. You can use an occluder. They call it a PDA occluder. So it's a very easy procedure now. It's done by the intervention structure doctor as well as the TE operator. It has to be under 3D TE. So this is the struts of the dehisced segments. And here you can see mechanical valve. This is a completely different patient from this one, where you can see the struts of the St. Jude mechanical valve, two discs over there, the struts around the valve, and this is the dehisced segment. And that will be the regurg in the 3D echo from that dehisced segment, because this is completely paravalvular, like we said. This is an LV view, and this is an LA view, but for different patients. Those patients, by the way, this is a 3D transthoracic, not transesophageal, and this is TEE. Both patients has mitral stenosis, rheumatic mitral stenosis. You can see the commissural fusion. However, this one has mild, this one has severe form of mitral stenosis. Like we used to call it the fish mouse appearance. So you can see the commissures are completely fused. There is no space here, both posterolateral and intermedial. So if you do eye crop for your patient during 3D, you can get a very meticulous picture for the patient and to see very well the mitral valve pathology. As in here, for example, you can see a flail, P3, along with a chordal rupture in the atrial view. This is the LV view. You will not see much in the LV view, but you will see the mitral subvalvular apparatus. This is a nice patient with a cleft valve. You can see here that there is a deep cleft that just caused the P2 scalope to be halved into two parts. So this is a P2 scalope. You can see that the cleft is over there. In systole, in diastole, you will not see the regurg of the cleft. However, you will see it here in systole. See, you can see very well and measure exactly the positioning and the orthogonal orientation of the prolapse. The prolapsed segment and even the alignment of the segment. And here, this is a photorealistic image after you obtain the very nice 3D image for the prolapse, because this is a very good information for the surgeon as well. Even the vena contracta, you can get a very determinate and very accurate vena contracta area. It's comparable to the vena contracta area by cardiac MRI as well. Again, this is a prolapse, and you can see here that this is basically the area where there is a regurgitant orifice. So you can see it here. This is echo-free space, because just beneath the prolapse, this is a regurg. So you can see it very clearly. Okay, we'll just end up with a very interesting case in clinic. In my clinic, a patient came to me. He's a 47-year-old chap. He's healthy. He's been having a metallic mitral valve replacement due to rheumatic mitral stenosis back in 2014 in Zayed Hospital. And he came with jaundice, very high LDH, and indirect bilirubin. INR was very high, apparently due to the liver. The liver enzymes were high as well. So the patient presented with heart failure, but it was HFpEF. Ejection fraction was completely normal. I did lung ultrasound, it's all B lines, so he was clearly in heart failure. The TE at that time, transthoracic echo, showed severe grade 4 mitral regurg. So we had to do TE, because at that time we suspected whether the valve has stenosis or regurg, because also the gradients were very high across the valve. When the gradients are very high across the valve, you can either have stenosis or high velocity regurg can cause also high gradients, right? So this is the images by the 2D echo. Sorry, 3D echo. We'll move on to the 2D and then the 3D. However, the patient was anesthetized. We give midazolam, fentanyl, very light doses. I usually give the sedation myself. I don't like to knock the patient to sleep because I'd like the patient to be a little bit conscious, to be able to swallow the probe properly. And I don't want to play with the hemodynamics as well. So deep sedation is not really a good idea during TE. So as you can see here, this is the mechanical valve, and there is a gap here, which we said many times about it in other examples, that this is a dehiscence. And you can see that there is a severe mitral regurg going from around or periannular, around the valve. It's not coming from the valve itself. So that means the valve was okay. There is no valvular regurg. It's all paravalvular. Again, another view, 3 chambers view with the aorta here in face. You can see the struts and the ring, and you can see that there is significant mitral regurg. Okay, let's go to the 3D, which is a beauty, because you can see from here that this is basically the struts of the valve. You can see here the gaps. There's a gaps over here where the color imaging is coming. This is all paravalvular leaks. So you can see here one is at 12 o'clock position, and another one is at 2 o'clock position, another one at 7 o'clock position. So there's 3 gaps with 3 severe paravalvular leaks. So that was basically done on 3D beat 6. We did 6 beat acquisition. 6 beat acquisition, it's important to have a very nice image to see everything meticulously in the valve in a very good resolution. If you need to see the valve without color, we can go to only 1 beat, which is this one. I just remove the color so that I can see the gaps and what's going on. You can see that the valve is completely dehiscent, and there's gaps and dehiscence between the valve and the tissue. So this is a significant gap with a dehiscence and severe paravalvular leaks, but you have 3 leaks. So the thing that we spoke about this after that with the heart team, and we found that the patient has again severe tricuspid regurg. As you can see from here, this is a tricuspid valve. There is torrential, massive tricuspid regurg with pulmonary artery pressure around 70 or 80 millimeter mercury. This is a 3D image of the tricuspid valve. You can see how severe it is. We measured as well the vena contracta using this. So the thing that he has 2 problems. It's basically 2 major problems. And the patient is low risk. So I'm not sure what to do with this patient, whether you think this patient is good for surgery, or we can send to the intervention structural intervention cardiologist to put 3 PDA occluders. What's the best for these patients? It's open for discussions if you want to discuss now before we move on, because we're almost finished.
So I think we need to know the risk for this patient, the surgical risk, the age, the risk factor, and then decide accordingly. Of course, he's a surgical patient, or he needs to do something about this. And if he has a high surgical risk, so an occluder can do the job for these small gaps, because they are not too big. And even the tricuspid can improve after repairing this mitral paravalvular leak. The best accurate way to treat this condition would be surgical if he is fit for surgery. If he's not fit for surgery, so the occluder, transcutaneous occluder will do the job.
Wonderful. Yeah. Any more comments? Just pass the mic.
Thank you very much, Suhail from Zayed Military. So it's a 47 years old guy, and the diagnosis of HFpEF, that's need to be thought about. The second thing, clinically, it also is giving a picture of hemolysis, what you have shown. And the third thing, this clip application is a relatively safer procedure. So interventional team should be given a thought, should be given a chance if they can occlude it properly.
You mean occluders, not clips? You mean occluders?
Occluders.
Yeah, PDA occluders. Okay, but this is a low-risk patient. He's a 47-year-old. He had mitral valve replacement 2014. He has his HFpEF, not HFrEF. So ejection fraction is maintained. And we know why he had HFpEF, because of the severe mitral regurg, right? The patient came in the clinic. He's completely stable, but he had these symptoms. Sure, the cardiac biomarkers are very high. So just put yourself in your shoes. Would you like to have occluders in this low-risk patient? 3 occluders? Or another redo surgery would be more prudent?
I think if his risk is low, maybe surgery is a better option, definitely. Because the occlusion is not especially if you do more than one or two, maybe you might not be able to close properly. Again, he has tricuspid regurgitation, which need to be fixed. He's unlikely to recover after the repair of the mitral valve. So I think I would just send him for surgery without any hesitation and give Dr. Wali to fix it. Because again, I mean, the risk of the procedure itself, putting one occluder is a task. Putting two or three is even more, and that area will be crowded a lot more. You can affect also the motion of the aortic valve. So it's actually not straightforward. And again, you not fixed the tricuspid.
Yeah.
So I believe this is
This-
an answer. I mean, if he's low risk, the surgical repair will cover everything.
So this happens 10 years after the initial surgery. So we'll try closely to look for the reason why it happens, for any dehiscence, abscess, any infection, anything.
This is
That's
very good
very
question.
important to find out what is the etiological cause for this dehiscence after 10 years. If there is no reason, if there is no abscess, if there is no infection, probably I will go for the occluder.
We did blood cultures. We did a thorough history through the previous years on Malafi, and we just went through the history of the patient. He didn't have any signs or symptoms of effective endocarditis, which was a bit weird. I mean, was it just dysfunctional valve after the surgery or what? Because it's a bit weird. After 10 years, he gets this kind of
Exactly.
like paravalvular leaks, right? So I agree. The surgery was the option. After the heart team, we
So
said that the
in
surgery is the
absence
best
of
option.
this, no infection, no abscess, and no other reason, probably occluder will be okay.
Yeah. No, occluders for a low-risk patient, you can put one occluder.
Yeah.
According to the literature, there's no actually definite guidelines. But according to literature, it's not prudent to put 3 occluders in a young patient who is low risk. He doesn't have any other comorbid conditions, no diabetes, nothing. It's just one surgery done in the past. So a redo surgery will be still safe for him with this age. If you just calculated the Euro score, you will find it low to go undergo the surgery. Any more questions? Dr. Munir.
It's not a question. It's actually, I have something just to say. This presentation, Dr. Fadi is doing it for 1 year now. So nothing of these videos or nothing of these things, he took it from any website. The only picture he wrote from his colleague, because
Cortese.
before Dr. Fadi, when he was young, he was in the young, what was the?
I was young, yeah.
Yeah, no, he was in a committee, he was in an organization called Young Echocardiography.
International Young Academy
International
of Cardiology.
Young Academy.
When I
and
was
then-
young, Munir.
When he was young. And then when he crossed 40, they kick him out from there. So,
I joined the club.
yes. So he did everything from the scratch by himself. All these pictures, even this fist, how we put this here, how is the orientation for he did it everything. And actually he's doing it since the last year conference. And then few weeks back, he told me, Ahmed, I have something, but it will take time. I tell him, he sent me some videos actually. It looks amazing. I told him, we have to present it, and I think it will be actually. So he did everything by himself, all the videos, everything he did by himself. So thank you so much.
Thank you, Munir. Thank you very much. I appreciate it a lot. And to be honest, this is the first conference we present this nice workshop. So this is the first one.
You have to sell it.
I have to sell it? Would you buy it from me?
I will have to market.
Okay. So thank you very much.